An absolute avalanche of news to get into this week. We're going to attempt to make all of the information around last week's most favored nations and Medicare announcement for GLP-1 medications as clear as humanly possible as we can. And we're going to go over a lot of movement that's taken place in the GLP-1 space over the last few weeks, all to give you a better sort of picture of the state of the union as it relates to GLP-1 medications on this week's episode of On the Pen, the Weekly Dose podcast. Let's do it together.
Welcome to the On the Pen podcast with your host, Dave Knapp.
Welcome to the On the Pen podcast for this week, Tuesday, November 11th, 2025. Happy Veterans Day to each and every one of you who are out there listening. If you are a service member or were a service member, love someone who was a service member, we thank you for your service and recognize that we do not have the ability to talk about the things that we talk about, to have open dialogue, to have freedom, to pursue life, liberty, and happiness on our own, apart from the sacrifice that those of you have made. So today we honor the veterans in this country, and we thank you for being here today, and thank you for being the best part of what we do at On the Pen. Last week was obviously a huge week in obesity medicine. We have been teeing up for months and months and months the most favored nations executive order by the White House, of course, all being done under the framework this time around under the Inflation Reduction Act passed by the Biden administration, all which gives the government essentially a little bit of leverage to arbitrate the cost of medications in this country, something that long has been needed and now exists. And so through most favored nations, which is something that the first Trump administration tried to get through, they were able to be a little bit more effective this time around because of the IRA, the Inflation Reduction Act, which again gave them law to sort of operate within the confines to get all of these pharmaceutical companies to the table. And of course, they got the big ones in our world to the table over the last couple of months, Eli Lilly and Novo Nordisk, all ending up in an announcement that the direct consumer cash channels for these medications, the prices were going to come down. And that for Medicare and Medicaid recipients, especially, the price was going to, well, the market was going to open up in general. So we're going to try to help you make as much sense of that as humanly possible today. We're going to go through all the announcements, and as well as a closed press conference that we got to sit in with Dave Ricks, who's the CEO of Eli Lilly, after this all went down last week. So we're going to recap that. But I want to talk a little bit this afternoon right off the bat about just sort of the groundwork of what these medications are. If you're new to the channel, please drop an N in the channel chat next to your name and let me know that you're new here. We'd like to welcome you by name. But if you're just joining here and you're just learning about these medications for treating obesity, a lot of people just think of them as diabetes medications that sort of found their way into obesity because as a side effect, people lost weight. Well, this is actually something that's been known for a long time. In fact, in 1971, scientists uncovered an effect called the incretin effect. And basically this effect was something that scientists observed. And that's basically when you fed people sugar and they digested it through their stomach, there was a metabolic process that kicked in much faster than it did when it was just straight glucose injected into the veins. And this effect was known as the incretin effect, basically caused by a release of nutrient-stimulated hormones that set off a whole cascade of metabolic processes, including insulin release, including the slowing of digestion and the signaling of satiation in the brain. And so this happened in 1971. And then, of course, through this basically discovery of the incretin effect, they isolated a couple of these nutrient stimulated hormones, GIP, GLP-1, probably the most famous and well-known of the incretin hormones. The problem with these was that they had a half-life of only about 5 minutes. And as they would later come to find out, these incretin hormones are destroyed in our gut by a byproduct called DPP4, which is something that is run amok in your body if you are obese, overweight, have high inflammation, high adiposity, etc. And that destroys these incretin hormones. And so in the process of learning essentially about these hormones, and this is all well before protein engineering was something that was well understood, a scientist basically discovered a protein in the venom of Gila monsters that was able to be extracted and very closely mimicked human GLP-1. And that drug ultimately became known as exenatide. So that was the first GLP-1 when people talk about being on that weight loss shot. And it's brand new and you're going to grow a second head if you stay on that medication. We actually have 20 plus years of data on these drugs being in the wild, right? Exenatide being the first one. Byetta was actually made by Eli Lilly and had a half-life of about 4 hours. I'm getting somewhere with this for all of you who have been around here for a long time. I already know everything that I'm telling you right now. The next discovery really was just a discovery of how do we make this half-life longer, right? Because not only do you increase the efficacy if you can increase the half-life, but the peaks and valleys, the peaks and the troughs, they call it, right? The concentration of the medicine in your blood, right? How do you get the most benefit? So liraglutide was developed by Novo Nordisk. It was a once daily, approved initially for type 2 diabetes, but then ultimately for obesity. And this one's been around since 2009, I believe, a long time now. And that one lasted 24 hours, Saxenda Victoza. And then, of course, you had dulaglutide, which was the first once weekly developed by Eli Lilly, sort of on the backbone of this GLP-1 discovery called exenatide, and finding a way to extend the half-life by attaching it to a backbone is essentially a monoclonal antibody delivery system. And then ultimately that led to the discovery of semaglutide and the market being brought to market as Ozempic and Wegovy by Novo Nordisk. And then ultimately this combination of GLP-1 GIP that we have today, which is the king of the hills, Zepbound and Mounjaro from Eli Lilly. So all along the way, you see what's happening in the GLP-1 space is two things. How do we increase efficacy, both from when we're talking about metabolic disease, from how do we increase efficacy from a A1C control and a blood sugar control standpoint, and how do we increase efficacy from a weight loss standpoint, all while mitigating some of these side effects that are associated with the peaks and the troughs of the concentration of these drugs in your blood system. And so in comes a company called, well, there are many. There are over 80 incretins right now in clinical trials or early stage development across the pharmaceutical industry. And in stepped this company called Metsera. Okay, so we got this company called Metsera. Metsera has found a way to take two nutrient stimulated hormones and turn them into a once monthly injection. One is called Met033I. I'm not even going to hazard a guess at the name of these, but essentially you have a once a month GLP-1 and they have a once a month amylin analog, right? So amylin is another nutrient stimulated hormone co-secreted in the pancreas with insulin, but both of these works profoundly on the satiety and hunger signaling in the brain. And so that's really obviously appealing because as you look at the evolution of these drugs, exenatide from about 4 hours, a twice a day shot, to liraglutide, which is a once a day shot, to now all the current iterations of these medications that are once weekly. Now you have the proposition with a company like Metsera to have a once a month. And of course, there are other players in the game. Amgen, I think of Maritide, that's a once a month monoclonal antibody, a GLP, GIP blocker. So you've got these companies that are developing ways to take these drugs less often. And that alleviates some problems for patients, right? It's a little more steady output of the medication over that month rather than the peaks and valleys of a week, a calendar week. You're getting over a month. So you get, quite a few days of stability of a consistent amount of drugs in the system. To get potentially a better effect, right? But you also get, the reduction of the need for as many injector pens, right? You need potentially less manufacturing because you're making less drugs overall. So all of these things are potentially beneficial. And so you have this company, Metsera, who not only has these 2 once-a-month candidates, they have others in the pipeline too, but they have this program called Momentum. And Momentum is essentially a way to take all these peptides and make them orally bioavailable. Because one of the problems and the reason that we don't have more oral versions of these drugs on the market in pill form, which would be much easier to bring to market. You don't need cold storage. You don't need pens, just much easier to manufacture and potentially easier for some patients to take. The problem is that they're not orally bioavailable very easily. The things have to be done to the peptides in order to preserve them through your digestive tract so that they get absorbed appropriately. That's where this program called Momentum comes in, and they have a program, Metsera does, that allows these peptides to be protective. In early data, it looks to be even better than a technology that Novo Nordisk has in their oral semaglutide pill called Rybelsus, and the future oral Wegovy, which we'll have news to bring you later on in the podcast about. But they have this snack technology. They paid around $2 billion for this technology, actually. But the Momentum program from Metsera looks to be even better. So not only do they have these 2 really attractive candidates for obesity medicine, they also have this Momentum program that could help them turn some of their peptide drugs into orally bioavailable oral treatments. So you saw this tug of war back and forth over the last few weeks between Pfizer, a company who had a small molecule GLP-1, not a peptide, a small molecule that failed called danuglipron. It was very similar to orforglipron. If you've heard of that one, it's the one that at the FDA just granted a fast track authorization to Eli Lilly, meaning we could have orforglipron within the next couple of months hit the market. We'll talk about how much, how you get it, et cetera, et cetera. But this, you can see why this would have been attractive to a company like Novo, who paid so much money for the snack technology, which is now kind of becoming a bit outdated, perhaps not as effective. So they have to use more API in the pills. We know that we're getting high dose Wegovy orals coming here that uses, considerably amount more semaglutide per week than the once weekly injectable 2.4 milligrams. So all of these things have value, right? At the end of the day, Pfizer ends up winning the bid here for around $10 billion. And of course, the FTC didn't super love the idea of the duopoly of Novo Nordisk and Eli Lilly being preserved. And so for a host of reasons, Pfizer won out this battle for Metsera. So it'll be very interesting because I think that the pill element of this can't be understated. It seems to be one of the elements that seems to be ignored by the large pharmaceutical outlets that have covered this. They tend to talk more about the once a month. I think this has everything to do with the oral platform, at least as much as it has to do with the amylin once a month and the GLP once a month. That's just my own personal opinion. So you did see Pfizer ends up winning out in that battle, but you can see how the development and the evolution of these drugs sort of leads to the next generation of how can we make these drugs not only more effective, more powerful, treat more severe cases of metabolic disease, but how can we make it easier for the patients? How do we get by with less manufacturing, et cetera, et cetera? So Pfizer ends up winning out that battle. Now, here's some interesting news that came out of, we talk about the snack technology, SNAC. We talk about oral semaglutide. We got some insane news today that I hope you caught on one of the short videos that I did. If you haven't caught them, you can follow me on Instagram. You can follow me on TikTok. But we did post a short to YouTube as well. We got some interesting news coming out of Novo Nordisk, where we saw the clinical trial, the Evoke trial, which is a Rybelsus trial testing oral semaglutide in early onset Alzheimer's. Now, that trial actually wrapped up at the end of last month. We don't have data on it yet, but what we do have is Novo Nordisk posting positions to run an Alzheimer's program in the United States. And then a gentleman on LinkedIn who just announced his employ with Novo Nordisk as the head of the Alzheimer's essentially department for Europe and Canada at Novo Nordisk. And so we see Novo Nordisk putting the sort of the ducks in the row, which seems to be an indication that their trial data for Evoke, that oral Rybelsus, is moving along very well in this treatment of early Alzheimer's. Now, I say all this as somebody who's deeply invested in this. I have lost a grandfather to Alzheimer's. In fact, I'm going to spend time with my grandmother this afternoon, who also has Alzheimer's, to think that these treatments are around the corner for the next generation, shoot, maybe even for myself. To be able to take these treatments and ward off the vicious and ugly and debilitating disease that is Alzheimer's is such a powerful thing. And I cannot help but be so motivated and encouraged to be covering this news at such a time like this, where the future of medicine is really upon us. And all of these chronic diseases that have riddled our society could become a thing of the past. What an exciting thing, and what a privilege to be covering all of this as it unfolds in real time. But that's sort of what we have going on there with with Novo Nordisk in terms of their Evoke trial. It sounds like we might be getting some really good news on that front in the next couple of weeks here. Now, one of the other interesting things that came out of last week's announcement in the Oval Office, if you didn't catch it, we covered it end to end here on the pen on our YouTube channel. I hope that you'll go back and check it out if you didn't get the chance to. And also, if you're watching now, I hope that you'll take a moment to just hit the thumbs up button, hit the subscribe button, whether you're watching on Twitter or you're watching on YouTube. Your interaction with the content really helps to push this content out. So I rely on you. If you find the video helpful, if you find the information that we share helpful, the one ask that I have of you would be to just hit the subscribe button or hit the thumbs up button while you're listening here. And I also want to take just a quick moment to thank our first sponsor here, Shed. Now, Shed partnered with us about a month and a half ago. They are a end-to-end sort of all-encompassing care for people living with obesity. You can check them out at tryshed.com. If you're looking for access to the compounded medications because you don't have a good insurance coverage, or if you're looking for access to the branded medications and you're looking for that care, that one-on-one time with a physician, and coaching options available for you, because we know that people that get the coaching, the nutrition side of it, the sort of that wraparound care really do better long-term with these medications. You can go to tryshed.com. We'll have an OTP landing page up soon. But for the time being, if you want to save some money, sign up, use code OTP25, save 25%, and you'll be helping to support the work that we do. Thank you to Shed for being our premier sponsor here of the podcast. But what I wanted to tell you was something that was missed in the conversation last week at this White House announcement. Now, everybody heard that Eli Lilly received a priority review voucher exception for the drug orforglipron, which is their small molecule, which basically means we could see that hit the market within a couple of months. This is a program that the FDA announced a few months back. We thought that they would be going for that with orforglipron, knowing that they have like 1 billion doses already on the shelves waiting to be sent out to patients who get the prescription. We did learn that was granted. Now, in this news, a lot of this news conference was disjointed. A lot of it was off topic. And then, of course, there was an interruption because one of the guests of Eli Lilly actually fainted midway through the presentation. It was kind of a dramatic deal. But one of the things that got lumped in was this oral Wegovy. And people just presumed that oral Wegovy also received this priority review. Now, oral Wegovy has already been submitted to the FDA, and Novo Nordisk expects regulatory action on that by the end of the year already. So the priority review was not granted for oral Wegovy, but Novo Nordisk did receive a priority review. However, that was for what they are calling Wegovy Plus. I don't know if you caught that during the press conference where CEO Mike Dustar of Novo Nordisk actually referred to the 7.2 milligram dose, which is actually what they submitted and received the priority review for. It was 7.2 milligrams of Wegovy. Now, the amazing thing about 7.2 milligrams of injectable Wegovy is that the efficacy is right up there with tirzepatide, right? It's like right around that 21% weight loss over the same time that we saw similar weight loss for tirzepatide. So now you have Wegovy sort of, at least from a weight loss perspective, on equal footing, although I know that there's a lot of you out there who cannot possibly fathom that much semaglutide. But that did receive a priority review. And so we will likely see 7.2 milligrams of Wegovy hit the market sooner rather than later within the next couple of months here in the United States, at least the first part of 2026. Now, that leads me to all the pricing on Trump RX and Medicare and who qualifies and who doesn't, because I know there's still a lot of unanswered questions. And I unfortunately did not get to ask the questions that I had during the conference call or the closed press conference with Dave Ricks from Eli Lilly. But there were some points of clarity that were received, and I'm going to go through those. But for right now, what I want to do is just sort of lay the groundwork for what this means for Medicare patients, who's going to benefit and when, and what's happening with the Trump. What is Trump RX? Do you have to buy your medicine from Donald Trump? Is that how this works? We're going to lay that all out for you, and then how this is all going to work in the timelines on the cash pay. So essentially what was presented here is that the injectable GLP-1s will come out to an average of around $350, right? The only concrete prices that we got were actually from Eli Lilly, who said that their starting dose, 2.5 milligrams of Zepbound, was going to drop for cash pay patients through Lilly Direct from $349 to $299 for this 2.5 dose. What we also learned is that the subsequent doses will go up to $450. Now, what we did not, which is $50 off the current price, roughly. What we did not learn is whether that is going to tier up or whether it's going to go immediately from the 2.5 milligrams at $299 to the 5 milligrams at $450 and all the way up. We don't know the answer to that, although the prevailing wisdom within the folks that I am connected to is that it goes immediately to the $450. Now, $50 is not that much savings over what you're seeing currently with those prices. But one of the parts of the announcement that I don't think should be missed is that over the next 24 months, there is an agreement that those prices will come down to an average of $250. So while it wasn't a huge bump right away, over the next 2 years, those prices on those drugs will come down to $250 per this agreement. Now, the $50 off, when does that start? That actually starts January 1. And so these prices will go up on Trump RX by the end of the year, and they will be available through Lilly Direct and NovoCare starting the first of the year. Now, this is where it gets a bit confusing. Sorry, I feel like I got a sneeze coming any moment, and I'm just afraid of sneezing all over all of you right into the microphone. So one of the things that, thank you, Hambone. One of the things that people have been asking me on this Trump RX is, do I have to buy this through Trump RX? Well, the answer is no, you don't. Trump RX is just a list. It's simply a website that you can go to and find out all the companies that are offering a direct-to-consumer cash pay option that goes around the PBMs and find out what those drugs are being offered for on Trump RX. But you're actually still going to get your medicine the same way. If you're getting the vials right now, you're going to continue to get them through Lilly Direct. Just starting the first of the year, you'll be able to look at the prices and compare them on Trump RX, and then you'll be able to get them prescribed by your doctor and get them filled through Lilly Direct. Now, there is some interesting news about maybe one of the biggest pieces of news that come out in all this is that Eli Lilly is working on a approval from Medicare on the quick pens, So for those of you who are in the UK who get Mounjaro, those are the quick pens, right? They're very similar to an Ozempic pen where you dial up the dose and you can either dial it up or dial it down. Now, that's going to give patients and doctors a lot more flexibility when prescribing the higher dose, because in theory, a adjustable 15 milligram pen, which has 60 milligrams of medicine in it, could last a patient a very long time if prescribed that way by your doctor. Do you smell what I'm stepping in? So when you think about the price, you also have to think about the way that they factored this all in. Those are multi-use pens. And so if you're on, say, 7.5 milligrams and your doctor prescribes you a 15 milligram pen and prescribes you to take half the dose, of course, this is going to immediately cut the cost of the drug in half, because the other big announcement that Lilly made, and of course, all this is factored into how they're pricing all this stuff. The other concession that they made is that they're going to remove the 45-day fill requirement. Now, this was part of the Lilly press conference where we were able to validate that the 45-day fill was coming to an end on the Lilly Direct. Now, for anyone who is getting these medications through Lilly Direct, the vials aren't going anywhere, but once the quick pens are offered, the quick pens will be available to you as an option as well. So that price again is going to be $299 for the starter dose, and it's going to go up to $450 for the upper doses, although we're not clear on whether that tiers up or goes immediately to the high doses. On the topic of Wegovy, now this is where it gets a little trickier because we haven't seen exact pricing on Wegovy, only that the average cost will be around $350. So we don't know where the pricing for Wegovy is going to end up, but we know around the time this thing launches on Trump RX or goes live through Novo Care, these new prices, we're probably going to have a high dose of Wegovy at 7.2 milligrams. Now, the question to me that remains is, will that just be priced similarly to the other Wegovy doses? Are you going to pay the same for a 7.2 milligram pen you are for a 0.25 milligram pen, or is it going to tier up like the prices for Zepbound? So there's still some unanswered questions, but they also called it by a different name. They called it Wegovy Plus. So will it even be considered in this? Because this is one discrepancy that we highlighted on the post call with Dave Ricks, was that they very clearly, Dave Ricks on this closed press conference indicated that retatrutide will not necessarily be launched at most favored nation prices. That, in other words, that it was not included as part of these negotiations, and that really leaves the door open to questioning a lot of things here, because what we heard was this was going to be good for all the future drugs that these companies were coming out with. But that is definitely the opposite of what we heard from Dave Ricks in this closed session press conference that took place after the White House press briefing. And so that I found to be rather interesting as well. We're going to get into a little bit more of what came out of that, and we're going to get into Medicare and Medicaid and what that means for all of them. But before we do, I want to thank another one of our sponsors. I want to thank Claimable for being such great sponsors. Now, listen here. If you are having trouble getting your insurance to cover your medications, or they're dropping coverage, Claimable gives you the tools to fight back at getclaimable.com/OTP. It's about $40 is the cost, but you can save 10% by using code OTP10. Essentially what it's going to do is it's going to help you build a medical case and a legal case to fight back against your insurance denials. And they have about a 50% track record of getting patients back on their medication who lose access to their GLP-1s. Now, other medications have a higher track record of success, but these GLP-1s, as we all know, are pretty tricky. But when you think about a 50% track record of helping people get their medication back, GLP-1s for obesity, that's pretty good. And then it goes up to for like diabetes up to like 80%. So Claimable offers the tools to help you do that. Please check them out and thank them across the social media channels when you come across them for being a sponsor of On the Pen, because these are the companies that allow us to do this full time and be here with you and bring you the podcast each and every week. They are early adopters and believers in On the Pen and the work that we do here. So thank you to Claimable for being an excellent sponsor of On the Pen. Want to talk about this Medicare program and who it's going to affect and when. So the overarching thing to understand here is that essentially what the Trump administration has done here is arbitrate the cost of these GLP-1s for obesity down by essentially saying that we will open up the Medicare and Medicaid's markets, which is a conservatively 30 to 40 million people. But we'll do that only if you come to the table on cost. And again, the only reason that they're able to sort of carry out or have any enforcement behind this is because of the IRA, which sort of gave a little bit of teeth to the most favored nations executive order, which otherwise would have been straight just, the good nature of big pharma to come to the table on this. So again, it's kind of interesting to see. You'll never see this from politicians, but you don't have these prices that we got from the Trump administration without the legislation that was passed by the Biden administration. Sort of funny that they didn't intend to work together on this, but accidentally, once in my lifetime, both sides worked together accidentally for something really great to happen to patients. And this is objectively great, because essentially what you have here is Medicare, starting April 1st, will expand its formularies to include obesity medicine. Now, the early indications is that you'll have to have a BMI of 27 plus a comorbidity or a BMI higher of 35. 5. Those were the early indications that I saw, but those have not been quantified. But those are the early indications that if you have a BMI of 27 with a comorbidity or a BMI higher of 35 than 35 without a comorbidity, you will qualify under Medicare. Now, what they've arbitrated here is basically for the government to pay $245 a month per prescription. So Medicare, and this was in the Lilly press conference. Lilly expects 100% uptake by Part D plans in this pilot program. They expect full uptake. So starting April 1st, Lilly is expecting a full uptake from the Medicare program. And upon this launch, patients, presumably, again, based on early reporting, patients with a BMI of 27 plus a comorbidity or above 35 without a comorbidity will qualify for $50 GLP-1s. That's Zepbound, Wegovy, and all the orals that will be available on the market by then as well. So that's massive. 30 to 40 million people being able to get access to these medications is huge. Now, this is all under a pilot program, so we still want this codified. This is still better if it gets codified through the Treat and Reduce Obesity Act, which we still call for both sides of the aisle to act on. But these are basically rule changes instituted under a pilot program, which was actually a rule change that was added by the Biden administration. The Trump administration took it away, obviously, and this is what we predicted way back in January, to sort of help they took it off the table to basically come to the bargaining table with these pharmaceutical companies to get the cost down so that they could not only bring it to Medicare patients, but that they could bring it to Medicare patients for $50. Now, for Medicaid patients, now these are the state-run programs for lower income individuals and arguably some of the most vulnerable people in our country. Some of the most, they were not only left out of the branded conversation, but they're left out of the compounded conversation because even $200 or $300 a month is too much for them to pay for access to these treatments. Most Medicaid drugs don't even have a copay. So these Medicaid programs across the states will now be able to participate in these plans and pay that same $245 per prescription. So for the states that opt in, and this will be a huge savings on what these drugs cost them prior to, that will be a huge uptake for Medicaid patients, and most Medicaid patients in the states that do uptake this over the next few months will pay $0. So that is an amazing turn of events. Now that's going to vary by state. And again, the different states are going to uptake this and different states may opt out, but the $245 is much more appealing, especially when you think of the broad impacts on total overall health, reduction in all-cause mortality, reduction in major cardiovascular events, reduction in cancer, reduction in sleep apnea, reduction. I mean, every day these medications seem to, come out with new information that show just how much these medications have the capacity to save the American healthcare system. And so that is amazing news. 30 to 40 million people. Now, we heard from Novo Nordisk that their estimate was that about 1 million people are on compounds. Think about how much bigger of a deal adding these drugs is to Medicare and Medicaid when you consider that 30 to 40 million people will now become eligible for $50 or free or whatever the Medicaid rate ends up being in your various state. But the vast majority of those people will pay $50 maximum for access to care. When in reality, if they were on compounds, they're paying a couple $100, a few $100. This is a huge, this is bigger than anything that we've ever covered before. And this is an absolutely game-changing piece of information. So moving on into some of the other notes that I have here. The orforglipron and Wegovy pill, when those are approved, the starting doses of those are going to be $149, right? So if the pills for maintenance may be an option for you, if you're somebody who's hit maintenance, then you may be able to access a maintenance dose for $149. If you need the upper doses, they're going to go up to $350, which I think is pretty high considering the cost of the injectables are supposed to over the next 24 months work their way down to $250. But interesting nonetheless, $149. beats a sharp stick in the eye. And of course, if you're on Medicare or Medicaid, it'll be $50. So this is the cash pay price for Wegovy and Orfo, $149 to start, working its way up to higher doses. And of course, the quick pens, all of the Lilly direct to consumer stuff and Medicare stuff is incumbent upon the FDA approving that quick pen. It's already approved for their insulin product, so I don't see why and it's already approved across in other countries because that's what they're selling Manjaro in, is these quick pens. So I don't think that'll be too big of a deal. The quick pens will be available through their cash pay channels as well as vials. I know for the quick fill, that's quick pen, there's no refill requirement. How could there be, right? Because so many people are going to go right to the 15 milligram, even if you're on 5. I'm not condoning that. I'm just saying I know based upon what doctors are saying online right now that they intend to prescribe it that way. Take that for what it is. This isn't medical advice. This is just sharing information to empower you to have more competent and confident conversations with your doctor. I am just encouraging each and every one of you. There's about 308 people watching right now. Hit the subscribe button wherever you're watching. Put in the comments and let me know where you're watching. I'm curious to know if you're on Instagram, if you're on LinkedIn, if you're on Twitter, or on YouTube. Want to take a moment to thank our sponsors of the podcast, Shape'a. Now, Shape'a has helped me hit my lowest weight in 10 years as an adult. Just an amazing tool that they have. It's the numberless scale that I use every single day. I get on it and it gives me 10 days of aggregate data. So what's your pattern over the last 10 days been in terms of your weight loss? Right now, I'm actually in the gray. I had my numbers really dip down to 265, and then the next day they went back up to 268. So I've been showing gaining, but I'm at 268 right now, a couple pounds up above where I was, maybe some Halloween candy in there. I don't know, who knows, but we're back on track. We're doing what we can. And so the numberless scale is keeping me engaged in my health the way that the normal number scale doesn't. It's just magic. I've explained it 1,000 times to y'all. Like, I, on an intellectual level, know that when I step on the scale one day from the other and I'm up 5 pounds, I didn't gain 5 pounds of fat, but it has a tendency to derail me anyway. And so the numberless scale keeps me out of that loop, and it keeps me on the scale every day. And when I'm engaged with my scale, I'm engaged with my health. If you're interested in checking out the Shape'a scale, go to home.myshape'a.com/OTP, and then code OTP30 is going to save you 30% on the cost of the Shape'a scale. It's well worth it. Again, I really attribute the success that I've had over the last few months to being engaged with my Shape'a scale. So I want to thank them for being a podcast sponsor and helping us have this podcast each and every week. It's definitely them that allows us to do this. Hit the thumbs up button if you're enjoying the podcast. I want to say hi to some people because we are live today. I want to say hi to our friend, let's see here, Anna, welcome. Ray's watching on YouTube. Shelly's watching on YouTube from NYC. Pam is watching on YouTube from Illini. Welcome, Illinois, from your neighbor over in Iowa. Christy's watching from Indiana on YouTube. Joel's watching from California on YouTube. Ray is watching from beautiful California on YouTube. Ann is watching from Nebraska. Kathy's watching from Nebraska. A lot of Nebraska folks. Welcome in, Travis, all of our Nebraska friends. Bruce says quick pens are only recommended for 30 days. Originally in the UK, there was 5 doses in the pen, but are being adopted for US rollout to remove the excess dose. I haven't heard that last part of what you're saying there, but I know that this is a reason why a lot of the doctors online who shared news about obesity medicine were excited about this specific pen. But we'll have to see. Mimi, who was suddenly taken off the retatrutide trial, may be an indication that we're going to see retatrutide sooner rather than later. But really bummer news for Mimi, who was all of a sudden just left without her medicine. That was sort of breaking news on last week's live stream. Is watching from sunny Queensland, Australia. So welcome to our friend Mimi. It's always so great to have you here. Kathy, welcome. John's watching on YouTube. We got North Carolina, New York, Maine, Kentucky. Welcome, everybody. Thank you for being here, and thank you for being the best part of what we do. I want to open up the comments to any questions that you may have here in our last few minutes of the podcast today. Again, I want to thank everyone for hanging out with us. Thank everyone for being the best part of what we do, and invite you to just hit subscribe while you're watching here. We've covered a lot of information today. I hope that it was helpful. If it was, simply do me the favor of hitting the thumbs up button. And if you're listening on the podcast, one of the best ways that you can support the work that we do is just by giving us a 5-star rating and a review. That really helps push the podcast. In fact, this is some breaking news on our podcast this week. We are in the top 1% of all podcasts globally. This was news that I got this week. Top 1% of all podcasts globally. So you have helped us to do that here. So thank you for doing your work and for being the best part of what we do at On the Pen. Pam says, Dave, are you in Iowa? Yes, I am. I am in Iowa. Welcome. When do you think private insurance will catch up? So this is a great question and something that I think has come up many times over the last few days. Like a lot of people are saying, well, those of us with, the traditional insurance, what's going to happen here? Well, the hope is, I know, and why Lilly is bullish on this in their press conference is essentially, they do use the Part D formularies as sort of a formulary process as kind of like the benchmark for private and commercial insurance. It's an index point for commercial insurance to sort of figure their formularies and pricing. And so hopefully over time, over the next year or so, as these prices come into market, it will force market changes in the private market as well. And you'll see some prices go down there, as well as more wide assurance adoption. Like this couldn't have come at a better time, honestly, because so many plans were jettisoning these drugs because of the cost. Something had to happen on cost because the insurance uptake wasn't good. In fact, it seemed to have been going in the wrong direction and not the right direction. So this couldn't have come at a better time, in my opinion. Sarah says, hello from your neighbor in Slater. Welcome. Good to have you here. Always fun to see our Iowa peeps in here. I came on late, says Deanna, but will there be a cost reduction for people getting it through their company insurance? My company just switched plans and it may be covered now. That's sort of what we just talked about. So hopefully that helped you to understand the landscape. Again, Medicare tends to be an index point for private insurers. So hopefully we'll see the cost come down over the next few months on those private plans as well. I'm sure there's no info on grandfather in on Medicare. Grandfathered in what way? In what way, buddy? I've been covered with a $0 copay for 3 years, but now sweating bullets as my insurance is changing at the first of the year. Oh man, that has to be a very nerve-wracking time. Of course, if they deny your medication altogether, I hope you'll check out Claimable, our podcast sponsor. If there are no more questions, I want to say thank you so much for being here today. Thank you for recapping all this stuff. We're going to have more to come later this week. My head is honestly still spinning from last week and everything that all the news that happened. We will see ultimately if there is more information that comes out this week, but definitely stay tuned by hitting the subscribe button, hitting the thumbs up button. All of that helps to promote the work that we do and get this out here. Will we see a decrease in compounded pricing? Now, I think there's no way that this Medicare movement on price in the spring doesn't have an impact on compounds. I think with all of a sudden 30 to 40 million people, some of which who have been using compound, they have their branded costs go down to $50. I don't see how they can compete still at some of the prices that they're at now. So I think mid-year 2026, I think you will see definitely some drastic reductions in the cost of compounded medications. But I think that it can't be understated that we could see different enforcement happen on the compounding side. Of course, we're still waiting for the FDA's decision on the demonstrably difficult to compound list. It's called the DDC list. Of course, we heard a little bit from Novo and Lilly on in the Oval Office last week about their desire to see the FDA make movement on that. Both companies said there was not direct talks about compound enforcement in these talks. But I don't know that I believe that, right? I think that there very well could have been a wink and a nod, right? In as it relates to compounds. So we'll be following all that. It's all the more reason to make sure that you follow very closely what we do at On the Pen. Go over to our Substack at obesity.news, put your email address in there so that you can stay on top of the news as it comes out. take a couple more questions as they popped up. Dave, wouldn't maintenance be covered under Medicare? It absolutely should be. Even with private insurance, you want to make sure your doctor's using your starting weight. I'm on Medicare, and by the time they get to the coverage, I'll be on maintenance. How will we qualify? So your doctor should ultimately use your starting weight for maintenance, right? You should use your starting weight for maintenance. Why would you stay on compound when you get the name brand for these low prices? I think that's the whole point. I think there's a lot of moving parts to this, but I think one of the big parts that Lilly and Novo were calculating here was how do we compete, right? So I think you can thank the compounders in part for applying pressure on these drug companies to come to the table, because there's definitely was a level of competition that typically wouldn't be there for big pharma that was there because of the role that compounders filled, especially during the shortages. So I want to thank you all again for being here. Hit the thumbs up button before we go. Drop a comment in the video after we go off here. Tell me what your favorite part of the podcast was today. What was it? Was it the news about Metsera? Was it the news? I love that there's a third player getting into the game. Pfizer, of course, we wanted to see the duopoly broken up, but I do think Lilly really ran the cost, or Novo really ran the cost of Metsera up in that process. But I do like a third player getting in the game. Listen, we should have survodutide data from Boehringer Ingelheim anytime. Boehringer Ingelheim or Schmidt. We should get data from survodutide soon. I'm kind of worried that we don't have it now. I hope that it doesn't break my heart. And with that, thank you folks for being here. Thank you for being the best part of what we do at On the Pen. Couldn't, wouldn't, and shouldn't do it without you. If you have other questions, feel free to always send me an email, dave@onthepen.com, and check out otplinks.com to find more out about the sponsors and those who help pay the bills. And we got some great resources for you there as well. Check you all in the next one. Thanks for hanging out with me today.